All right, hello, welcome to today's episode on hypercalcemia. So to start out, we have the CP Solvers diagnostic schema. Great schema. I would only add a couple things as we go through this, but there are some important clinical pearls and things to know when discussing hypercalcemia. So, number one, um, it's important to know that most patients are going to have mild or subclinical hypercalcemia. Okay, and a lot of patients, even in the hospital setting, they'll have mild hypercalcemia for various reasons or unknown reasons, and the calcium will correct with 1 to 3 liters of fluids or any amount of fluids. Okay, and this won't warrant a further workup. Okay. The second thing to know is that most patients with hypercalcemia, this is due to overactivity of the parathyroid gland. So most patients have hyperparathyroid hypercalcemia. Okay, and again, this is typically clinically silent. Um, However, an important pearl within my second point is that even though patients sometimes have a baseline of hyperparathyroidism, this may not lead to an increase in calcium or very mild increases in calcium, and it's not until the patient has a second hit, whether it be the use of thiazide diuretics, increasing their vitamin D intake, or eating Tums because they have an ulcer, or maybe they even have cancer. But the point is that a lot of times patients will have hyperparathyroidism that is clinically silent, and it's not until that second hit that their calcium levels increase or they become symptomatic. So that's important to keep in mind. Another thing to note is that patients with an extremely elevated calcium level um, will typically have malignancy over an overactive parathyroid gland. Okay, so patients with a calcium greater than 14 favors malignancy. Last thing to note is that a patient that comes in with constipation and polyuria, you should be thinking hypercalcemia because there's not many things, if anything else, that causes these two constellation of symptoms besides elevated blood calcium. Constipation and polyuria, think hypercalcemia. And a lot of times patients are not going to have your typical bones, groans, moans, and psychiatric overtones unless they have a very elevated calcium level, which again would typically favor some sort of malignancy or granulomatosis. Um, so if a patient has, say, constipation, then after getting labs, definitely think about hypercalcemia. All right, so let's get right into this. So the best way to approach hypercalcemia, in my opinion, is doing it through an endocrine approach. Okay, so I like the way CP Solvers has this broken down. Um, they first start out by asking, is this a PTH versus a non-PTH mediated process? Okay. They also point out that there are 3 different hormones that regulate calcium in the blood, and these include obviously our PTH, number one, our parathyroid related peptide, number two, and then vitamin D, number three, and specifically the active form of vitamin D, which would be 125 hydroxyvitamin D. Okay, so those are the hormones responsible for calcium regulation. So it's important to get those labs if you see fit, or just have those hormones in the back of your mind as potential causes of elevated calcium. All right. So a very, very important point to note is that when checking a PTH, if the patient's PTH is normal, if it's normal, this is pathologic. Okay. Patients should have a suppressed PTH. Um, and notice how this is not always true, that a lot of times if a patient has normal or low hormone levels preceding whatever elevated abnormality that follows, it's usually not pathologic, but this is one of those exceptions where a normal level of PTH is considered pathologic. Okay, notice how this differs from an increase in, or excuse me, a 25 hydroxy vitamin D level down here. Um, if you are suspecting vitamin D mediated hypercalcemia, you get a 125 hydroxy vitamin D and it's elevated, and you want to differentiate between increased vitamin D intake versus a granulomatous disease, for example, then getting back a normal level of 25 hydroxy vitamin D um, is uh, is not pathologic, because that's what the body should be doing. Okay. All right, moving on. So we're taking an endocrinologic approach here. We're first getting a PTH, which will be step one. Write out our steps over here. Let's make this look a little neater. First thing you do is you want to get that PTH, just like we said. Caveat to this is that PTH sometimes takes a little bit of time to get back from the lab. So there's an alternative approach to get around this PTH level. If you just have your basic labs, you can look at the chloride to phos ratio. Okay. And if this is greater than 33, this equals PTH mediated. And the reason why is that PTH increases the excretion of phosphorus in the urine. Okay, so phosphorus will be low in the blood, and phosphorus will be high in the urine if you got a urine phos. But in order for the body to maintain electroneutrality, then we reabsorb chloride as we get rid of the phosphorus. In other words, you should have an elevated chloride. So if you take the um, chloride to phosphorus ratio and it's greater than 33, then this tells us that this is a PTH mediated process. Okay, that is a nice little pearl. Next thing that we can do after this is we can check the vitamin D. Make this a little more concise. And I would always start with 125 vitamin D first, because if this is increased, that tells us that there's abnormal conversion of 25 hydroxyvitamin D to 125 hydroxyvitamin D. This could be due to increased vitamin D intake. That's why we would check the 25 hydroxyvitamin D level if we were suspecting excess vitamin D intake, and it should be increased. If it's normal or decreased, that tells us that there is something else going on that is making this enzyme hyperactive. If in fact we see that we are suspecting abnormal conversion in the absence of excess vitamin D intake, then you got to think of granulomatous diseases such as TB or sarcoid or other types of fungal infections, in addition to borreliosis or foreign body digestion. Okay. So there's our mycoses down here, and then really there's two reasons why you could have an elevated 125 hydroxyvitamin D in the absence of excess vitamin D intake, and at that point you are considering, like we said, the granulomas, or malignancy. And the typical malignancy to cause this in the absence of bone affiliation is going to be your Hodgkin's lymphoma. Okay. All right. Maybe there's other types of lymphoma that does this too, but classically, your Hodgkin's lymphoma can be associated with increased calcium in the setting of increase 125 hydroxy vitamin D enzyme, whatever it is. Okay. Now, really, the first thing you want to do, as I said, is decide whether or not this is a PTH mediated process. And if it turns out that it is not a PTH mediated process, then you have to be thinking either vitamin D mediated or parathyroid related peptide mediated. And your typical association with parathyroid related peptide is by and large squamous cell carcinoma. That could be lung, could be some other skin malignancy or what have you. But typical is squamous cell carcinoma causing an increase in parathyroid-related peptide. Also think about renal cell carcinoma as well. Next, if all of these come back negative, parathyroid-related peptide, we have a decrease in our parathyroid-related hormone. This tells us that, and we have normal vitamin D levels, then this tells us we're dealing with more likely one of these other rare causes, or lytic bone disease. And so lytic bone disease, I like the way that the CP Solvers breaks this down into malignancy here. However, there's a couple other bone processes that can lead to hypercalcemia besides just lytic bone disease. So immobilization, which is associated with osteoporosis, especially in children, can cause an increase in calcium due to increased bone turnover. So let me do this here. I like the idea of adding things to this lytic bone disease. But let's see here. Let's just do this. Let's create another box here. Sorry about that. Whoops. Let's create another box here and put increase in bone turnover. And this could be due to something called Paget's disease, where you have an increase in bone modeling and turnover, acromegaly, hyperthyroid, which causes increased bone turnover, osteoporosis. And again, this, like hyperthyroidism, actually leads to osteoporosis and causes increase in bone turnover. So these are mentioned over here in the endocrine section. And again, if you're thinking of these like acromegaly, you would likely assess on physical exam. There might be other signs of adrenal insufficiency. I'm actually not sure how adrenal insufficiency leads to hypercalcemia. I apologize for not knowing that mechanism, but another thing to consider when considering hormone mediated outside of the top three, and again, like we said, hyperparathyroid or hypo can actually do it as well, but more commonly hyper. I also like to branch this out and include meds as a separate tab and not just other. Because again, for example, if a patient has this kind of subclinical hyperparathyroidism, and then they're taking diuretics or lithium, and this can um, classically kind of unmask primary hyperparathyroidism, um, leading to hypercalcemia. Um, right, immobilization down here. It's thought that, well, let's think about it like this. So we know that bone responds in terms of growth to the forces in which acts upon the bone. So bone grows to whatever forces are acting on the bone. And so if you're immobile, you have really essentially no force acting on the bone, and so you're going to have increase in bone turnover. If you see a pediatric patient with long bone fractures, there's a lot of bone turnover, and this can lead to hypercalcemia. So that's kind of the mechanism of the immobilization. Milk alkali syndrome is not very common anymore. It's typically due to patients with GI upset that don't have access to PPIs or H2 blockers, and they'll just be taking Tums and Tums and Tums to try to relieve their upset stomach, and it can lead to hypercalcemia. Vitamin A, that's the only other one. I'm not sure what the mechanism is behind that causes the hypercalcemia. So just something to remember. But all in all, the way to approach this is through understanding the hormones that regulate calcium. So take an endocrine approach, and first check the PTH, calculate the chloride to phos ratio to quickly see whether this is PTH mediated or not. If it is PTH mediated, most commonly it's just going to be your sporadic hyperparathyroidism. This genetic condition, familial hypocalciuric hypercalcemia, this is very rare, and if you're suspecting it, then just check urine chloride. Okay. Min 1 and 2A. Unsure of that mechanism as well, but just another thing to keep in the back of your mind. Uh, Tertiary hyperparathyroidism in the setting of renal failure is possible. And then parathyroid carcinoma accounts for about 1% of all of the PTH mediated hypercalcemia. If your parathyroid hormone is low, right, because we said normal or high is PTH mediated, if it's low, we're dealing with a non-PTH mediated hypercalcemia, and there's select causes. Go through the most common causes first. So you should be thinking malignancy or granulomatosis disease if the clinical picture fits. And next, don't forget about endocrine as well as uh, medications. So we can add that to the list. So endocrine and other endo conditions, and depending on what you suspect, then you should be ordering tests that follow, like we talked about. If you're suspecting the familial hypocalciuric hypercalcemia, get the urinary chloride. If you're suspecting granulomatous disease, then start your vitamin D workup, and so on and so forth. Get a parathyroid related peptide test. All right, so that just about does it. Thanks.